You've probably seen this a million times on a scan, a renal cyst. It is one of the most common things we find by accident in medicine. But finding one can open up a real diagnostic rabbit hole, leading you anywhere from totally harmless to we need to act on this right now. So how do we make sense of them? So there you are. Your patient got a scan for something completely different, and boom, there it is. The report hits your desk. Is this nothing to worry about? Or is this the very first clue to something much, much bigger? That's the big question we're going to tackle in this explainer. So here's our game plan. First, we'll figure out if a single cyst looks dangerous. Then we'll zoom out to what it means when the kidneys are full of them. We'll touch on some genetic syndromes, look at tricky mimics, and then I'll give you a simple checklist to tie it all together for your daily practice. Okay, first things first. You see a cyst. Your number one job is to figure out the risk. And the go-to tool, the one you absolutely have to have in your back pocket, is the Bosniak classification system. All right, let's walk through this, because the details really matter. A class I is your classic simple cyst. On a CT, it's basically water density, less than 15 Hounsfield units, and the risk is basically 0. Class 2 might have a tiny hairline-thin wall or a little bit of calcification, but it's still benign. Now see that IIF? The F stands for follow-up. Here things are a little thicker, a little more concerning, pushing the risk to about 5%. But the real jump, the one you got to pay attention to, is to class 3. Now we're talking thick walls or a solid lump, what we call a mural nodule. And finally, class 4 is when you see any solid part that lights up with contrast. That's considered cancer until you prove it's not. Let's just stop on this for a second. 50%. The second a cyst hits the criteria for Bosniak 3, you're looking at a coin flip for whether it's cancer. This is the most important number to remember. It's the line in the sand where we stop saying, let's watch it, and start having a very serious talk about surgery. Okay, so that's how we handle one cyst. But what if the scan comes back and the kidney doesn't just have a cyst? It looks more like a bag of grapes. Well, now we're in the world of the classic hereditary polycystic diseases. The two big ones here sound almost the same, but trust me, they are completely different beasts. On the left is the adult form, ADPKD. The things to remember here are liver cysts, super common, and that really scary risk of berry aneurysms in the brain. But on the right, you have the pediatric form, ARPKD, and look at the difference. In the liver, you see fibrosis, not cysts, and these poor kids get terrible hypertension and can go into renal failure really early on. Now, to round out that pediatric differential, there's one more you gotta know, multicystic dysplastic kidney. And here's the curveball. This one is not hereditary. It's just a fluke of development where one kidney doesn't form right and is basically useless from birth. And you know what this really highlights? The importance of always checking the other kidney, because about half the time it's got its own problems like a blockage or reflux. Okay, so let's zoom out even further. Sometimes that renal cyst isn't the main event. It's just one clue in a much bigger multi-system detective story. If you see renal cysts and then you also see things popping up in the pancreas, the adrenal glands, or the brain and spinal cord, your alarm bells should be ringing for von Hippel-Lindau disease. Now here's the critical part. VHL patients don't just get cysts. They have a super high risk, we're talking up to 50%, that those cysts will turn into clear cell renal cell carcinoma. The kidney stuff is just one piece of a much larger puzzle. And it's a similar story with tuberous sclerosis. Here, the body is growing benign tumors or hamartomas all over the place. And in the kidney, the classic finding isn't just cysts, it's these multiple fatty tumors called angiomyolipomas, or AMLs. When you see those, especially along with findings in the brain, heart, or lungs, you have to be thinking TSC. And hey, here's a little pearl for you, something to impress your attending with on rounds. An old school name for tuberous sclerosis is Bourneville disease. Just a little fun fact for your back pocket. All right, so we've met the hereditary bad guys and the big genetic syndromes. Now let's talk about the imposters, the mimics, the things that are really designed to trip you up. I love this quote from one of the sources because, well, it's a bit colorful, but it just perfectly captures that feeling of frustration, right? You get a scan with no clinical history, just this ugly, complex-looking thing in the kidney, and you have to decide, is this a tumor or could this be a raging infection? It can be a seriously tough call. So how do you tell them apart? This is where you have to use your clinical spidey sense. You know, a history of fever or a UTI is a huge clue pointing you toward an abscess. But if you don't have that, look for the subtle signs on the scan itself. See that hazy stranding in the fat around the kidney? Or that thickened renal fascia? Those things just scream inflammation, not tumor. Okay, another really important category is what happens to dialysis patients. Their original kidneys, they're not really working anymore, and over time they start to form cysts. And look at those numbers. The longer someone's on dialysis, the higher the risk. After 5 years, it's almost a sure thing. And here's why that matters so much. This condition significantly bumps up the risk of getting renal cell carcinoma. That's why we screen them. And hey, don't forget to check the med list. Long-term lithium use can create a really specific picture. The kidneys aren't huge and cystic, they're actually normal-sized or even a bit small, but they are just peppered with tons of these tiny little microcysts. It's a very distinct look, and if you see it and you know the patient is on lithium, you've pretty much got your answer. All right, here's a quick one that trips people up all the time. Parapelvic versus peripelvic. It sounds like splitting hairs, but it matters. Just remember this. Parapelvic starts in the parenchyma, the actual meat of the kidney, and it bulges in, squishing the collecting system. But a peripelvic cyst starts on the perimeter, in the fatty renal sinus around the collecting system, which is why it can look exactly like a blocked kidney. It's all about where it comes from. Phew. Okay, we have covered a ton of ground. So let's pull it all together into a super simple, actionable checklist you can use every single time you see a renal cyst. Here it is, your 4-step framework. Just ask yourself these questions. Number 1, is it simple or complex? That's your Bosniak classification. Number 2, is it one cyst or are there a bunch? If there are many, start thinking about your polycystic diseases. Number 3, are other organs involved? That's your cue to think about genetic syndromes like VHL or tuberous sclerosis. And finally, number 4, and this is so important, what's the story? What's the clinical context? Is there a history of infection, dialysis, or specific medications? This simple funnel will get you to the right answer almost every time. So we'll end with a little challenge for you. On an MRI, a normal, simple cyst is full of water, so it should be super bright on a T2 weighted scan. So what if you see one that's dark? What should be on your differential? Well, this forces you to think outside the box. It could be blood, right? A hemorrhagic cyst. It could be a tricky mimic, like a lipid-poor AML, or, it could be a specific type of cancer, like a papillary RCC. It's a great final reminder that even with the best checklist, the kidney can always find a way to surprise you.